This is a fast-growing issue, and I want to bring it up in specific to us because there are lots of Oklahomans that I talk to that don't see this as a big issue. Let me just tell you, it's a very big issue. We've got a PowerPoint. Is that working? There you go. Okay, let's go. I think 2 more. That's it right there. Just watch this. This will loop several times. What this map is, obviously a map of the United States. The colors as they get darker are the increase of the number of deaths per 100,000 people in that county due to opioids. It starts in 1979, and you can see it really in Los Angeles and New York. And then it starts accelerating. Look at the middle of the country. You can't see the outline of any state in the middle of the country except ours. You notice that? Look at it again. All right, stop it right there at the most current time, if you don't mind. That's from 2011 to 2015. It's gotten worse since that time period. Again, looking in the middle of the country, we're dealing with something Texas is not, Kansas is not, Nebraska is not, North and South Dakota aren't dealing with it the same way, Arkansas is not dealing with this, Louisiana's not dealing with this. I have folks that say this is a national problem. It is a bigger problem in Oklahoma than it is in the rest of all of Central Time. I'm going to ask us to have family conversations to say why. Why is this a bigger problem in opioids in our state and not in the states around us? So here's what we're trying to do to be able to work through the process. Some of them are national, some of them are state issues, some of them are local government, a bunch of it's family and how we all handle it. Those conversations around the dinner table and permission we give to people to be able to work through the process is completely different. So here's what we're trying to do on the national level. A year and a half ago, we passed a bill called CARA. It started getting some funding and specifically towards individuals who have opioid addictions that then overdose, that first responders will have more access to Narcan, which can neutralize it and help literally bring people back to life at that point if they can get to them fast enough. It also deals with some of the relationships between the state and the federal government and sharing information. There's some other stuff. That was passed. One of the things myself and 2 other senators worked on was something really odd we found. The Center for Medicare and Medicaid Services reimburses a hospital at a higher rate if they're a quality hospital. That's a good thing. We want to incentivize hospitals to be a quality hospital and say the Medicare will pay you more if you're a high-quality hospital, so meet the standards. The problem was one of the standards they had out there was you deal with all pain. So when you leave the hospital, you would fill out a survey. Some of you have done this before and didn't realize what it was for. And it had a question, did the hospital manage all of my pain while I was in the hospital? Now, a hospital is not a hotel. You're going to have pain when you're in the hospital. That's not a shock to anybody. But the hospitals were incentivized to use the highest level of drugs they could to treat pain while they're in the hospital, because if the patient left and said, I had any pain while I was in the hospital, that hospital would be paid less for their services. So if they wanted to be paid more for their services, they had to use the highest level of drugs they could to make sure they could. That gave a much greater chance that that person, when they left the hospital, had had multiple days of opioids while they were in the hospital and could have an addiction when they walk out. Opioid addiction is not about wealth and poverty. It's not about one county or another. You can look at that map of Oklahoma and see it's across the state. Rural, urban, suburban, it's everywhere. So one of the issues we're trying to deal with is to change that. By the way, the 3 of us worked our tail off, worked with CMS. CMS pulled that off of the list. They no longer reimburse hospitals anymore based on how they deal with pain. So we've taken away that financial incentive for hospitals to put additional stuff into it. Now, by the way, if you leave the hospital and you're still in pain, don't blame it on me, okay? The other thing that we're trying to do is this. We've worked with the NIH, National Institute for Health, and their research. Ask the question, what are we doing to develop pain medicines that are not addictive? NIH has done something revolutionary. They pulled 30 drug companies together that all compete with each other, and they're working with those 30 drug companies to share their research with each other to get to a faster solution of how do we get to a pain medicine that actually deals with pain but is not addictive at the end of it. People have legitimate pain. Probably some people in this room deal with chronic back pain and other things from an accident or whatever it might have been in the past. They need something to be able to help them just get through the day to be able to manage the pain, but they don't need the dangers of the opioids on top of it. So they're aggressively taking that on. Fourth aspect to that is interdiction. Narcotics used to come from Afghanistan. Heroin, black tar heroin, white heroin, those things used to come from Afghanistan. Now the Mexican cartels actually grow poppies in large quantities. And most of the fake opioid prescription pills, the prescriptions mixed with fentanyl, which is killing people all over the country in our state, and heroin is coming straight out of Mexico. We've got to work with the Mexican government to clear those poppy fields, and we've got to deal with interdiction because the cartels are bringing it in and they're selling it in large quantities. Oklahoma happens to be at the crossroads of 3 major highways, and it is easy for them to be able to move those drugs in any direction in our state. It's a big issue for us. So we've got to deal with that interdiction. How are we stopping the flow? If you go back 20 years before, remember the aggressive move on cocaine, both crack cocaine and powder cocaine? There was a lot of work in Colombia to try to reduce the quantities down, and it made a difference. We saw cocaine drop in usage over the decades. We can do that again, but we need to be very intentional about it. To be able to work with the government of Mexico and to be able to work on our border enforcement in that specific area where drugs are being able to move into our country. So that's an issue I want to be able to bring because it's not only a national issue, our state leaders, they recognize it, but it's a matter of funding it and how to be able to deal with treatment and how to be able to deal with processing it, but it all begins with a family conversation as well. If you've got a family member that is connected to those opioids, love on them, walk them through a very difficult addiction, but understand it doesn't get better with time, it gets worse with time. The story I hear over and over again from people is they started with prescription opioids, then they couldn't get the quantity they needed, and they went to the street and they bought the fake opioid prescriptions, and they ended up getting heroin because it was even cheaper than the fake pills, and their life was spiraling out of control. Get to them as fast as you can.